Hi, Bhaskar.
We are live now, sir. Good evening, esteemed faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of She Connect, welcoming you all for today's webinar, AMOGS Emergency Obstetrics Committee with Jharkhand Societies. And today's episode is 58. So it's my privilege to introduce the convener of today's webinar, Dr. Nivedita Datta ma'am. Ma'am is the past president of Bokaro OBGYN Society, consultant at KM Memorial Hospital and Research Center. Ma'am has so many accolades to her credit. I welcome you, ma'am, and I hand over the session to you.
Thank you, Sahiti. It's indeed a pleasure to be here with you all and welcoming you all to Jharkhand, albeit virtually. Today we have with us 3 societies from Jharkhand. We have Bokaro, from which I'm a member. We have Deoghar and we have Dhanbad societies. And we have esteemed faculties with us. We have Dr. Bhaskar Pal, President-elect. We have Dr. Parag, who's the President ICG. And it is a great pleasure to invite Dr. Sneha Bhuyar right now. She has like, if you see her CV, it begins from somewhere and ends like, if I start reading it, I think we'll be just using time out here. But what is most important beyond the CV is that she's a genuinely very nice person. She's academically fantastic. We've all, a lot of us have heard her during when she was the chairperson breast committee. She is now she's also got a very nice heart. She's very close. She remembers. That's why I was amazed that she remembered Kavita from Bistrit days. I would request you all to give her a round of applause. And please, 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 she's contesting for vice president to ensure that the votes from Jharkhand go to her. Dr. Sneha, in the dais is all yours, and I invite you.
Yeah, thank you. Thank you so much, Dr. Nivedita, for that, very warm introduction, I would say. A very good evening to one and all. My respect and regards to all the seniors here, especially Dr. Bhaskar Pal, the president-elect, and Dr. Kiran Kurtakoti, the president of AMOGS, who are the chief guests for today's program. And of course, Dr. Parag Biniwale, who is the ICOG chair, a very dear friend, and Madam Shivani Jha, and of course, our dear friend, Dr. Apurva Datta, who have gratefully accepted to be the guest of honor. So I thank all of you and welcome all of you. Of course, Nivedita and Monica, thank you for, all the hard work you are doing for me. I would like to welcome each every faculty and of course the members of all the 3 societies, the president and secretaries of Dhanbad, Deoghar and Bokaro. I would like to welcome each and every member of this program. I think because Dr. Bhaskar has to leave for his flights, I will be addressing each one of you personally later on. We would just like to have, his precious words for all of us, precious words of guidance. So Dr. Bhaskar Pal is a very highly...
Please, I don't need to be introduced in Jharkhand.
I'm not
Jharkhand,
going
I don't
to
need introduced.
Please stop sharing. I would just straightway invite Dr. Bhaskar Pal for his precious words of guidance.
Thank you.
We're very happy to have you, Bhaskar.
Thank you. Right at the outset, I'm really grateful for being bestowed this honor of being the chief guest for this webinar. I keep saying that of all the state organizations, AMOGS is the pioneer and the most vibrant. And you can see there, they have a flurry of activities. The webinars by AMOGS, this particular committee, Dr. Sneha Bhuyar has been relentless in trying to spread knowledge. And congratulations to you, Sneha, for that. It's a pleasure to be among friends, Dr. Kiran, Dr. Parag, Shivani Jha Madam, Apurva, Nivedita, Monica, who's still not here, and Arpita Di, and all the faculty. I think we will have a very, very fruitful webinar. What is important is to know that we know for the first time, India's maternal mortality fell for the 2018 to 2020 to 97. And we were worried that whether it will go up for the effect of COVID, but now we have the data not only from 20 to 22, but we have the data from 19 to 21 and 20 to 22. From 20 to 22, the Indian maternal mortality has actually fallen to 87. And that has happened essentially because The gynecologists all across the country have done a great job in delivering in their services, and the government has taken a proactive view. And webinars like this have a big role to play in making childbirth safe. I congratulate Sneha and Monica for organizing this, and I wish this webinar all the best. Before I sign off, I would like to wish Sneha all the best for her forthcoming Vice President elections and Monica for her forthcoming committee chair elections. Thank you very much for having me.
Thank you so much. Thank you so much, Bhaskar, for your wishes. It mean a lot for us. Thank you so much once again for your words of wisdom. And of course, I think Dr. Kiran was a little busy. I don't see him joining, but I think we'll have his words a little later once he joins. By the time, may I invite Dr. Parag Biniwale, who is the ICOG chairperson and of course, PG teacher and unit head at Kamala Nehru Hospital and in Pune, and he was the president of Pune AMOGS Emergency Society. All of you know him as the chairperson of Young Talent Promotion Committee, a very dear friend, of course, a illustrious personality as well. May we invite Dr. Parag for your precious words as well.
Yeah, thank you, Sneha. Good evening. I bring greetings from ICOG and of course AMOGS. Being the national coordinator of AMOGS, it gives me immense pride that Sneha, you are working so hard for the AMOGS Emergency Obstetrics Committee. In fact, you have taken AMOGS to beyond the boundaries of Maharashtra, and the tie-ups that you've done with the states like Uttar Pradesh, now Jharkhand, earlier it was Bihar, where there's still high maternal mortality. I think it is really important to have a dialogue and discussion with the practitioners in these areas so that there would be an exchange of knowledge. We learn from them what difficulties they are facing, and of course, we by panel discussion we can give them some tips or guidance, and then that would certainly help saving lives of our women. So thank you very much for having me here. My best wishes for the program, and of course, best wishes to you for the forthcoming election. I can see AMOG's president here, so I think let's
Yes.
give the
Welcome.
dais to him. Thank you.
So thank you so much, Parag. So after the God Almighty's blessings and of course, President-elect Dr. Bhaskar Pal's best wishes and Dr. Parag Biniwale. Actually, we missed you in between, Dr. Kiran. So may we invite you for your words of guidance for this, event.
Thank you.
We have clubbed with Jharkhand Societies.
Yeah.
So
Thank you.
okay.
Thank you, Dr. Sneha.
Okay.
I hope I am audible. Thank you. I mean, I was in between a surgery, so that is why you can see me in the hospital. So thank you so much, Sneha. I mean, you have gathered the entire Jharkhand Societies, and it's really a pleasure for me to be the chief guest at this occasion. Topics, as usual, they are one of the best which you have chosen, and moreover, that your involvement into this particular program is so high that really you have taken everyone along with it, and not only the program quality is improved, but you have created a bond between entire Maharashtra and individual states. So that is what is most important. So as a leader, I really thank you for taking AMOGS to different parts of India. So thank you so much, Dr. Sneha. Of course, best wishes from AMOGS to you and your candidature. And I request you to get on with the program. My regards to Dr. Bhaskar also and Dr. Parag also.
Yes. Thank you so much.
Thank you, Nivedita ji. Dr. Nivedita, thank you. Yes, please visit again Pune sometimes. I will give the vote of thanks to you that time also. Thank you so much.
So thank you so much, Dr. Kiran,
you.
for your precious words, as well as, we are very, we are privileged to have you as chief guest. In between the surgery, you could find some time to join. That is why we are really thankful to you. Thank you once again. So with God Almighty's blessings and respected seniors' blessings, we would like to go ahead with the academic session. Of course, Madam Shivani Jha's blessings are very, very important. And Madam, what I can share for Madam is she's such a senior obstetrician, and all of us have lots to learn from her. What we share together is the Unsung Hero Award, Dr. S.N. Malhotra Award, which I had received in 2008. That was the first, and Madam has also received the same award. So, we have a very good heart-to-heart connect with you, Madam. We're very eager to listen to your precious words. Please, over to you.
Thank you, Madam. Thank you, Sneha. Good evening, everyone. It's truly an honor and privilege to be a part of this meaningful webinar organized by AMOGS. I extend my heartfelt thanks to the organizing committee for inviting me as a guest of honor for this evening session. I feel immensely proud to share this platform with such a esteemed dignitaries, our respected chief guest, Dr. Bhaskar Pal, President-elect Foxy, and Dr. Kiran, President AMOGS. It's inspiring to be alongside visionary who continue to shape the future of women's health in India. A special thanks to my fellow guest of honor, Dr. Pirag Binawale, and National Coordinator AMOGS, Dr. Apurva Datta, Chairperson Sexual Medicine Committee FOXI. Your contribution are pivotal in addressing some most sensitive and important issues in our field. My sincere gratitude to AMOGS and Dr. Sneha Bhuyar for this opportunity. Wishing her the best in all the future endeavor. I wish the webinar great success and hope it brings further valuable discussion that guide us all towards better patient care and awareness. It's so lovely to see all the familiar faces on this one platform. Dr. Nivedita, Dr. Arpita, Dr. Kavita Priya, and Dr. Reena Varnawal, Dr. Durga, and Varsa. Everyone from the All Jharkhand Society. Thank you once again, and my best wishes to Sneha for candidates. Thank you. Thank you.
Madam, thank you so much. Thank you so much, Madam, for your all your words of wisdom as well as your blessings. Thank you so much, Madam. I'm very happy to see you, Apurva, on the screen. We are very, Purba and me, we have worked very closely as he was my the member of the breast committee. And of course, he was there for all our activities. So I'm very happy to see him going ahead as a chairperson. And we are really proud of you, Purba, for the so many, it's such a long list of awards, I would say. So I'm not going to read this. We have already displayed. But yes, Foxy Dr. Shanti Yadav Award for Infertility, Rangila Sinha Young Gynecologist Award for 22. In addition to, yes,
thank you so much. Thank you so much,
awards. Yes, so please go ahead with your precious words, Apurva. We're very happy to.
Ma'am, first of all, ma'am, thank you so much because as a MOC and as a convener and as a coordinator. Now मेरे को लग रहा है आपने मुझे आज special guest and guest of honor बनाया. Ma'am, what to say about it, ma'am? Thank you so much for all the honor. Ma'am, I know and I admire you. You are an inspiration that how you run the committee. A committee from which is not known to everyone. You made this committee so vibrant. That is study on breast committee. I have participated your breastcon at the Pune, and a committee, I think probably this is the first time any committee chairperson has done a 2 days full. 2 halls are running simultaneously on the conferences. So, ma'am, hats off to your dedications and hats off. I know you and I think from last 1 decades, and to know you, it's really an honor. So thank you so much, ma'am, and thank you to all the participants, all because it's my own state. So thank you, Nivedita, ma'am, and to have along with my motherly figure, Dr. Shivani Jha, ma'am, it's really, really wonderful. And about, ma'am, it's not only the breast. I know you are such a wonderful obstetrician and you are practicing obstetrics in such a small place. Because I always admire, because we are working in a small place, and those person who are actually working in a place, these all are an inspiration in a small resources. So thank you so much, ma'am, for being part of this webinar, and you are being such an inspiration for all of us. And all the very best to you. And I am really requesting all of you from Jharkhand who have joined, please spread this message that yes, it deserved to be the vice president this year. So please vote for ma'am, and all the very best for the future endeavor. And definitely, ma'am, I just want to work under you. And thank you so much, ma'am. Thank you. Thank you so much,
Thank you,
ma'am.
my dear. Thank you so much. I can just say that, I am a all-inclusive person. Thank you, Apurva, for sharing that. Apurva used to be the MOC coordinator for organizing our breast committee program, and see where he has reached. So we are really proud of you, Apurva, and I want to work with all of you. So
thank you so much, ma'am. And ma'am, I still remember during the COVID time when Alpesh Gandhi sir has I think that is joined by more than 15,000.
yeah,
People,
breastfeeding
and it was
program was 60,000.
breastfeeding program, and I'm part
60,000.
of that.
Yes.
Yes, ma'am, I have part of that, and I think it is by Saiya Sati from the community people. People are
Yeah.
there, and your slides are in Hindi, your slides are in Marathi. So you are such a wonderful leader, ma'am. So thank you so much, ma'am, for always being an inspiration for all of us. Thank you, ma'am.
Thank you, Apurva. Thank you so much. So with this, I would like to thank all the president and secretaries of Devghar, especially Madam Arpita Gandhi and Priyanka Rai as the secretary, and of course, Bokaro, Dr. Meeta Sinha and Varuna Verma, and for Dhanbad Society, of course, Dr. Komal Singh and Dr. Reena Barnwal. I would like to thank Nivedita and Monica once again, and with the blessings of God Almighty, I think we have had a wonderful inaugural session. We would like to go ahead with the academic session. And for this, I would hand over to you, Dr. Nivedita. Thank you so much.
Dr. Monica has not joined. It's this time, one thing wonderful about this session which Dr. Sneha has conceived is that it's a panel. It's just a panel with discussions, so that everybody can put in their inputs, get the outputs from Dr. Sneha and the other people who are sitting out there, and everybody and the audience as well as the panelists can go back home with a good take-home message, rather than having innumerable talks and the webinar dragging along for a very long time. This is short, sweet. Hi, Dr. Anita. Dr. Anita's here. This is short, sweet, crisp, lucid, and I hope very, very informative to everyone. So we are going to tackle something. The panel is going to be on obstetric emergencies. We are all hardcore obstetricians, and all of us face emergencies at some time or the other. So let's come forward, discuss these obstetric emergencies, and to moderate the panel, we have none other than Dr. Sneha Bhuyan, who's going to do a wonderful job of moderation as well as giving clear take-home messages. Dr. Sneha?
Yes. Thank you so much, Dr. Nivedita. No need to introduce me now. You have had enough introduction. We just welcome you. Yeah. Yeah, so Madam Arpita Gandhi, whom I know so well since the last Bhagalpur conference, especially she has hosted us. We have visited the Baba Baidyanath, and Devghar Society is very close to my heart. Madam, welcome as expert for this panel. And of course, we have Nivedita, Dr. Nivedita Datta. Yes, a very vibrant personality, very honest and genuine from the heart. Past president of Bokaro AMOGS Society, and of course, a very active member of the Safe Motherhood Committee. I think though she has association with NGOs like Zapago, National Health Systems, and she has trained so many. So welcome, Dr. Nivedita. So next, all the panelists, Dr. Jyoti Gupta from Bokaro, Dr. Kusum Prakash from Bokaro, Dr. Shivani. I think Shivani has conveyed that she will not be able to join. Dr. Sweeti Bhagat from Bokaro, Dr. Kavita Priya, whom I just got introduced well, and I remember her, since the visited days. Dr. Isha Rani from Dhanbad, Dr. Durga Patwari from Dhanbad, and Dr. Varsha from Dhanbad, Dr. Divya from AMOGS Devghar, Dr. Neha Priya Devgar and Dr. Simi Kumari from Devgar, Dr. Shikha Sahai from AMOGS Devgar, Dr. Rani from Francis Hospital Devgar. So I welcome all of you, my dear, and let us, let us learn together. Okay. So I hope you can see my screen. Yes, and it is full screen. So, friends, childbirth is the sentinel event in the woman's life and her family as well. I'm sure you must have heard in olden days, people used to say it's a second birth or rebirth of this woman when she goes into labor. So birth is not only intensely emotional, but also intensely physical as well. And it's not that easy, 1, 2, 3 push and the baby is out and everything is happy as it is shown in the movies. Basically, it's a delivery of a healthy baby from a healthy mother, and for the mother it should be a fulfilling experience. Of course, it has to be a respectful maternity care. So I'm sure all of us, whether we were as a trainee obstetrician or now as senior practicing obstetrician, I'm sure there's always a dilemma in management of labor. Even the WHO labor care guide, they are also changing. The partogram is changing over the days, and this management, of course, will depend whether you are the proponent of the active management of labor, that is odorous cause follower, or you are the protagonist of the, watchful expectancy and master activity. So without much ado, we go ahead with this case discussions. Here we have this first case, 35-year-old grand multigravida. She delivered by Dai at home and placenta is also removed at home, brought to the labor room with profuse bleeding. The vitals are, she's got tachycardia, BP 90/50, and so she has got profuse bleeding and hypotension and tachycardia. So what is your primary diagnosis? What is your primary diagnosis from this clinical history? Who is the panelist taking this? Yes, please go ahead. From this history only, delivered at home, placenta removed, but she started bleeding profuse. So it's a case of postpartum hemorrhage, but exactly the findings are not given, only postpartum hemorrhage, and she is in shock. So what is, this is the picture. So now what is this diagnosis?
This is uterine inversion.
Yeah, please stop. Yeah, uterine inversion, you can see very clearly, right? So actually this Dr. Jyoti, this is a case for him. Purposefully the picture is shown here. Actually, what tips you have to give is when you examine the per abdominally, the uterus was not felt, and locally there was a gush of blood. She was just lying in a gush of blood, and there was a fleshy mass which was seen here. So Dr. Jyoti, yeah, it is uterine inversion. How do you manage this patient?
Good evening, everyone.
Good evening.
Can you hear me?
Yes, definitely.
Yes. So, first we will like to settle her shock. So, we will start with the IV fluid, ABC. We will start with that. And after that, we will examine the patient. And if it is inversion, we will try to find out what is the degree of the inversion. And we will try to, immediately, if we try to repose it, put it inside, it may sometimes work. So with one hand, we will try to push the uterus in, and if that fails, then we will take her to the OT.
How do you do that? How do you reduce the? How do you repose?
You have to, with one hand on the abdomen, the other hand pushes with the palm of the hand on the fundus of the uterus, which is inverted, and fingers on the rim of the cervix. We try to push it inside with a little bit of Trendelenburg position of the patient, so that the head is lower and the feet is high. And if that fails, then we have to think about the hydrostatic.
So whether the fundus goes first or the lower part?
No, the fundus goes first.
Tell me. Yes, how it happens.
So the fundus goes first.
No, I mean, how would you? How you want to push the fundus directly? Can it go, or through the cervical ring?
Through the cervical ring, we will have to push it inside.
So the part which comes last.
Yeah, that will be the fundus, na? That will come last. So that has to be pushed first.
Fundus will come first.
Okay, you mean to say that the part which is near
when it is coming as an inversion,
cervical rim, that we will try to push. Correct.
Fundal
Okay.
part dips first, right? That is how
Okay.
you see. See, this is the grading. This is the grading. The only a part of the fundus, you can see from the, there are some diagrams here. Only the part of the fundus, if that dips first, right? See this. This part
Correct.
dips first, okay? Then fundus comes first, body comes, then the cervical part, the lower part. So the part comes last, right? The cervical comes last. So that should go first, so that, the cervical ring dilates,
Correct.
right? Okay. So this is how it is. Okay. Then you will push it. See, you can see here in this picture also, you can see the part. You can see the abdominal and the vaginal part here. Okay. So the cervical part will go first. The fundus goes last, right?
Correct.
And then you keep your hand inside. Okay. Then what you do once you push it? Dr.
Then we
Kusum?
can start with the oxytocin.
Yeah.
So and keep your hand for some time there. And once the contractions are established, then you can remove your hand.
Okay.
And then observe the patient.
Yes. So for how long you want to give the oxytocin infusion? How long do you want
For 6 to 8 hours.
Yes. How much oxytocin you want to give infusion?
If it is infusion, we generally give 20 units of Cinto in 5% dextrose.
Yeah, that is for the first infusion. And once you regain the tone of the uterus, you may taper it down to 10 units. But you have to continue it for 6 to 8 hours. Anything else you want to add? You are doing so much of manipulations here. So anything else you want to give it to the patient?
Antibiotics?
Yes, perfect. So see, these are the steps as we talking. You can see the first, this is the arrow is showing the first part, the cervical ring goes first, and then the body, and then the fundus, right?
Correct.
Right. No, now if this doesn't happen, then what will you do?
Then we need to shift the patient to the OT, and then we can try the hydrostatic method, which is also called as the O-Sullivan's method, where we put an infusion into the vagina, posterior fornix, and through the pressure of the fluid, we will try to repose the uterus into the abdomen.
Okay. If that also doesn't happen, then what will you do?
Then actually, I have not tackled any case of uterine inversion, so it's just theoretical I'm talking about.
Yeah, yeah.
So what is mentioned is either you can do it abdominally, per abdominally with laparotomy, or through vagina.
Okay.
So most preferred is through abdomen, and that is named as the Huntington's operation.
Okay.
So you give a midline incision, then with the help of the LA's forceps, you can just try to push the round ligaments or the cornea of the uterus up.
What is this procedure? Before that, very simple. What is this procedure? Yeah.
With the fingertips, you can try to pull the uterus up near the cervical rim.
Yeah. So with posterior hand and anterior hand, then you try to push the flip the fingers upwards like this.
Correct.
So that the fundus rises, and then the dimple disappears. That is how it is. This is the simple measure. If this doesn't help, then of course you have to go ahead with the Huntington's operation, what you described, just with the help of Ellie's, little you advance. Okay. Anybody else wants to take up this? Next, Dr. Kusum. Do we have Dr. Kusum? Okay. Anybody else wants to add to this Huntington's operation? With the round ligament, you trace them. Then what is the Halton's procedure? Suppose this also doesn't help, then what is the Halton's procedure?
Giving incision in the posterior surface of uterus to bisect the constriction ring in the myometrium, which is preventing the reduction of inversion.
Right. And then you suture it, whatever you have cut, right? That is Halton's. And this is what is the Halton's procedure, right? I'm sure you have this picture, right? So this is how you incise, you push the uterus up, and then you close the defect, whatever you have incised, right? Though this is quite uncommon, I'm sure even today the fresh inversion is quite common. Even at cesarean section, sometimes it happens, right? What can be the causes? We would just talk about that. What precautions? This is quite rare, so we leave apart that, you know, we don't need to go for so many operative procedures. With simple reposition it happens. But what are the precautions to avoid this situation? Dr. Kavita, will be very happy to have from you, listen to you. Can you please unmute yourself? No, we can't hear you, Dr. Kavita, we can't hear you. The voice, I think you have joined without. Yes,
I
yes.
think you can hear me now.
Yeah.
So the precautions we take to prevent uterine inversion, first we anticipate that certain cases will be problematic, like the grand multipara, and those are general precautions that we take, that we hold a degree of anticipation that things can go wrong with some people, with some patients. Then when we deliver the mother, then we avoid doing too much traction of the, we avoid unnecessary traction to the cord.
Right.
So that, because that can pull out the uterus and invert it.
Yeah.
So
in other words, I would just say, what are the predisposing factors? In which patients you feel that it is more common?
Predisposing factors will be, it is common, one, where the where there is a short cord, where there is increased intra-abdominal pressure. For example, if the patient has a lot of coughing, or if she's straining too much, more than she should, that will cause it. Then if she is a grand multiplara with a very with an atonic uterus and tired atonic uterus, that will cause it. So those are.
And if it is an adherent placenta,
and
if
yes,
it is adherent
placenta
placenta, you continue to, yes. And of course,
and a male baby, but we don't know. We are not supposed to know that.
Yeah, mismanaged third stage of labor. So all this, once we know that, we have already enumerated the list of causes. So if you try and avoid all these aggravating factors, definitely, you know, we can avoid the inversion of uterus. So now we go ahead with the second case. Now, Dr. Sweety, this is a case for you. Do we have Dr. Sweety Bhagat?
Hello. Good evening, ma'am.
Yeah, good evening. So we have this primary gravida, 37 weeks. She comes in early labor. Her contractions are 25 seconds every 4 minutes. Fetal heart is good, but her head is floating. And in those, soon after, in some time, you find that there is sudden drop in fetal heart. What do you feel can be the possible reasons? How to manage this situation?
Ma'am, if the pregnant lady is more than 37 weeks, so we can go for investigations like
no, I'm telling you now, here she's already in early labor. She's having floating head and fetal heart is 140. And now suddenly there is a fetal heart drop. So what is the reason? What could have happened here?
Sudden drop in fetal heart rate.
Yes. Right?
Cord, maybe the cord has been
yeah, but
loop
then
of cord is around the neck.
Diagnosis? How will you come to the diagnosis? Floating head at term, patient in early labor, suddenly
cord prolapse. You think of cord prolapse. Membrane must have ruptured and the cord has slipped beyond the head.
Perfect. So naturally, how do you confirm it? How do you come to the diagnosis?
By PV examination.
Examination will do.
Examination.
Okay. Anybody can take up this. Then I would ask Dr. Nivedita only to complete the discussion. Yes, Nivedita.
Okay, it's pretty simple, because what you've seen, a sudden drop of heartbeat. There can be, it's huge. A sudden drop of heartbeat is always a cord complication. So either it has been a true knot which has suddenly got tight, or it is a cord prolapse. But since your case is given a high floating head, so definitely it's a cord prolapse. Now the best way to when it's a cord prolapse, a per abdominal examination obviously show a high floating head, a low heart rate, or maybe even a very low heart rate. And when you do a per speculum or a vaginal examination, you will see the cord, either the cord is outside or the cord is in the vagina. And And then if the how to manage it is that, I mean, if the management is for some other
Yes.
panelists, it's fine.
No worries. I invited you as an expert, so no problem. Basically,
so manage it. Now, when you have got a case of cord prolapse, what we advise is first is raise the foot end, try to repose the cord, and then pack the vagina with a tetra or a towel, whatever you have soaked in normal saline. That prevents drying of the cord. And then immediately shift the patient to the operation theater if your operation theater is in the vicinity. If the operation theater is not in the vicinity, please do the C-section where she is, because you have to take out the baby fast. So deliver the baby. Now, sometimes in one case, one of our colleagues found a cord prolapse when the patient was in 8 centimeter dilatation, and she pushed in the cord, she got the cord inside, and she delivered the baby by vacuum. So, but that is, I wouldn't really recommend it, because with a slightly, when the head is not very well engaged, then trying it by vacuum is like going pretty dangerously close to medical legal problems. But definitely pack the vagina, put in the cord, repose the cord, pack the vagina, and go in for a C-section.
Yes, perfect. So the case has been already discussed very well by Dr. Nivedita. I would just tell you that, anytime, whenever you have a floating head near term, keep a very high index of suspicion that this patient may likely to go into spontaneous rupture of membranes and cord prolapse. Okay, RCOG also recommends that such patients, all of you must have a ultrasonography on admission. Okay, so first and foremost, we talk about the emergency. What you will do, sudden drop in fetal heart, you see whether she really has had her spontaneous rupture of membranes. And if you see that the membranes are ruptured, then you do internal examination. You see whether she has got cord prolapse. Even if you don't find that there is a cord prolapse, there can be occult cord prolapse. Okay, so the in between the myometrium, the uterine wall and the fetal presenting part, cord may have got compressed. That is also one more possibility. So what is called as occult cord prolapse, that is cord compression. So it can be either occult cord prolapse, which is, in between the presenting part and the uterine wall, which is contracting, or maybe a frank or overt cord prolapse. Sometimes there can be phoenic presentation. So if I talk to you now, whenever you find floating head, please go ahead for the ultrasound. See that the cord is not lying beyond the presenting part. If it is lying beyond the presenting part, it is called as phoenic presentation or cord presentation. For such patient, absolutely don't allow her to go into labor and go for elective cesarean section. That is what is the dictum. Now, what I'm asking you is what Dr. Nivedita has discussed, that if you have a live baby, you have to go ahead with cesarean section as soon as possible. And the second message is, in fact, you have to deliver the baby by whatever modality, whichever is the earliest. So if she is near full dilatation, best way is to deliver her. But if she is not, then of course go for cesarean section at the earliest. No matter whether she is dilated or not, don't wait for vaginal delivery. The moment you see cord prolapse, at least start preparing for the cesarean section so that you don't lose any time. Right. Madam Shivani, any addition from your side?
Hello, ma'am. I just wanted to ask, in this case, can we fill the bladder to elevate the head so that it doesn't compresses the cord while we are moving the patient to the operation theater?
Sorry?
Yeah. So actually, yes. So let me just tell you that, these are things which are actually theoretically described. Now, if we obstetricians are managing, I'm sure Madam also has experience, and Nivedita also. If at all you face cord prolapse, you don't have anything in your hand but to call the anesthetist and get the OT ready. But meanwhile, yes, you can give a fetal, you can full the bladder. Maybe you elevate her legs, or maybe you put her on 4 limbs, that is knee chest position. Okay? So everything, whatever you can do best is okay, but your aim should be to deliver the baby as soon as possible.
Yes,
right, Vedita?
Yeah, absolutely. I don't have
Can
any
I add?
experience.
Yes.
Can I add something?
Yes,
Like this cord prolapse is so sudden. First of all, we have to see that that it doesn't go into the vasospasm. And at times in our, like, I'm in a very small town, we do not get the anesthetist also.
Yes.
At times it has happened that I have asked my staff that just give IV anesthesia, and I have taken out the baby, and the result was fantastic. Although the baby was admitted in NICU for 4 or 5 days, but I could save the baby. Many times it happens, and in this case, I do not go for this signature also, because he is saying, I just explained, देखो नहीं क्या है, जल्दी नहीं करेंगे तो दिक्कत है, ऑपरेशन पे अनुमति दो, and that's vital. I go for this response because they are seeing that this madam is working on a barcode, and really I'm very glad that I have saved almost 10 or 12 cases in my lifetime, in 30 years of my experience.
Yes. So the message here is to deliver the baby as soon as possible by whatever modality. That is what is the first message, as Dr. Arpita Madam has also said, that yes, she has also shared her experience. Second thing is whether the patient delivers vaginally or no, we have to keep OT and everything ready, including her informed written consent, because we have to save the patient and the baby, but we have to save ourselves also. So that is what, the moment you see this emergency, one of your person from your team will, get engaged into all these activities, so keeping the operation theater ready, keeping the anesthetist ready, neonatologist ready, and taking the informed written consent. So you have to delegate your work to your team, but then you have to make sure that you yourself don't move from the patient, and you try to deliver the baby as soon as possible. I think that should be the message from our side. And if at all, the one more message was that Punic, yes. Dr. Nivedita, yes. Please go ahead.
I also would like to tell the audience here that please document and communicate, because these are the cases where we face problems. So even they can see you hurrying, but if you do not inform them, and if something goes wrong with the baby, then you're stuck.
Yes, you have to take an informed written consent that this is the situation the patient has reported to us or patient has presented, but we will try our best, but this assurance you should never give. So informed written consent, you have to inform and take a written consent of the adverse outcome as well. So I think that's a message very, very, it's a must, I would say. Thank you so much. Once again, we go ahead with the next case now. We have, I'm sure I'm trying to make it very practical. We don't go for any guidelines, this, that, whatever is useful for the practicing obstetrician. Simple cases, 28-year-old lady, fourth gravida with previous 2 abortions. Now she is 39 weeks and in labor. She delivers a full-term baby girl, but the placenta fails to expel even after 45 minutes of birth. Dr. Durga, what is your clinical diagnosis here? Dr. Durga?
Yes, ma'am.
Yeah. So what?
Case of retained placenta.
Yes, perfect. That is the perfect answer. Now you tell me, how would you go ahead with the management?
Ma'am, first of all, we will ensure an IV line, antibiotics, and the USG is very helpful at this point. We will catheterize the patient, and we will then do manual removal of placenta under general
so
anesthesia.
whether, I will just interrupt you here, whether you will start only IV line or you will start an oxytocin.
Oxytocin, definitely, ma'am.
Okay, so oxytocin. So why I'm trying to ask you is because there may be some simple adherent placenta or some placenta which have got separated but retained inside. Absolutely. Or maybe some have not separated at all. So since what happens, the full bladder may lead to atony of the uterus, right? Yes. So that's the reason either you ask the patient to pass urine or maybe catheterize, and then you start oxytocin. But suppose the patient is not bleeding absolutely. So even after 45 minutes, you will try and you will directly go for MRP, or you will do ultrasound at this point of time.
Ma'am, we can do a go for ultrasound.
We will go for ultrasound.
That is
The dictum is if the patient is not bleeding, do not handle the placenta.
Yes.
If she is bleeding, only then try to remove the placenta. That is the dictum. Not
The
bleeding.
very fact that she is not bleeding, that means the placenta is not getting separated. So it can be a case of morbidly adherent placenta. What we call nowadays is PAS, placenta accreta spectrum, right? So it is the best time, rather than going hurriedly for manual removal of placenta without any preparation. Wait, hold on. If you have ultrasound in your hospital, well and good, in the labor room. If no, even then she's not bleeding, why the hurry? So go ahead for ultrasound. Get a documentation that yes, there is a plane of cleavage, it's not adherent. Then you take her to operation theatre and go ahead with MRP. Otherwise, if it is adherent placenta, then you arrange for everything. We'll discuss it. Now, suppose it's a simple adherent placenta. How will you go ahead with the manual removal of placenta? Dr. Durga, please continue.
Ma'am will hold the umbilical cord with a clamp and pull the clamp gently. And with all sterile precaution, we will insert our hands into the uterus.
Okay.
And we will try to find a cleavage between the placenta and the uterine wall while keeping the fundus with the other hand. And then we will...
both your hands are utilized here only at present. You are holding the clamp or the cord with one hand with gentle traction, and you are trying to pass your the other hand, the right hand, along the cord, go to the surface of the placenta, go to the edge of the placenta, then you try to insinuate, and then you separate from all around, right? Separate from all around, then you turn the placenta as if you are turning the book of the page, right?
Yes.
And then you, with same hand you come out, right? So you remove the placenta at the same time. Now with your other hand, you stabilize the uterus.
Yes.
Okay. Okay. And then what you do once you remove it?
Placenta.
Placenta.
Then
will you
then
give
we will get uterotonics.
Uterotonics. Perfect. One. And so you're asking your assistant to give uterotonics. Your other hand is stabilizing the uterus because you don't want the uterus to get inverted, right? And you hold the uterus for both the things. You see the tone. And now what you do next? Whether you
massage. Ma'am, then we will see that the whole of the placenta is ensure that all the placental tissue has been removed.
Yes, both the aspects of placenta, whether fetal as well as maternal aspect. So that on maternal aspect, what do you see? Whether something is remaining inside. And for the fetal aspect,
we will examine the placenta.
Yes, fetal aspect also. Yes, if at all you have a succensurate lobe of placenta, you see the tendons and the vessels extending beyond your limits of the placenta, right? So you get the idea that there is something more inside, and that is all. Then you keep doing, somebody said, bimanual massage, compression, and then you continue with the right. If at all she bleeds, then different. But suppose now if that is morbidly adherent placenta, PAS, then I would ask the other person, I think, whom should I ask? Madam, Dr. Rani, or anybody else? I would say anybody else. Please take up this. If it is a placenta accreta spectrum, if it is an accreta or increta, what will you do for this patient?
Go for umbilical cord knotting with thread and leave it as such for some time. If it is not bleeding, we can take it out after giving methotrexate.
What about the placenta? What about the placenta? You leave it inside?
Yes, ma'am. If it is placenta accreta, I will leave it inside. If it is not bleeding, hemodynamically patient is stable, I will go for leaving the placenta.
Yeah. So is anybody differs from this?
Ma'am, depending upon the other ends, actually we can do a abdominal approach, like we can go for a laparotomy And if it's like a segmental one, we can do a segmental resection, and sometimes this may lead into like hysterectomy also. Rather than keeping placenta inside, it's a source of infection, even though there are many studies showing that there is good outcome, but long term it will be having more of like a complication associated with that. Maybe going for renal failure too.
Right. So let me share with you that maybe around 35 years ago, when I was a PG student, we have managed many cases leaving behind the placenta and giving methotrexate. Okay. But what the evidence says and what is our experience also. Some of the patients, maybe 3-4 patients we have done, 2-3 patients were okay. They, spontaneously the placenta got necrose, expelled, and with the methotrexate, we thought that it was because of methotrexate. But what evidence says, methotrexate works only on the dividing cells. Okay. And this placenta is actually, it is not a dividing tissue. It is actually a necrosing tissue, right? So methotrexate will never work on this. Correct? Secondly, when you leave behind this placenta, it's a source of infection through the cord. The patient can sometimes go into septicemic shock, or maybe with sepsis, she can go into what is called a secondary PPH, which can be even torrential. People have lost such patients. Okay. So evidence doesn't allow you nowadays to keep the placenta in situ with methotrexate treatment, right? So make it very clear that if at all you leave behind the placenta and give methotrexate and something goes wrong with the patient, you are not forgiven. Okay. So please remember not to leave the placenta. Now comes the next thing, as somebody has talked about, who was talking about the treatment, obstetric hysterectomy?
Ma'am, Dr. Divya.
Dr. Divya. So very correct. You are very right that even if this is the case when you have documented placenta accreta spectrum, you're not supposed to leave it behind. You go for definitive management. Now, this was only para 1, only one issue she has. But if at all it is a patchy adherence, means at some places, but if the patient is not bleeding at all, you are sure that it is a generalized adherence. Okay. So for this patient, you have to either go for obstetric hysterectomy if at all it is, bleeding profusely. If it is not bleeding profusely, you can take a choice what is called as uterine conservative surgery. And there are 2-3 surgeries. One is triple P procedure. Can anybody talk about triple P procedure from the panelist? Anybody? Somebody was talking about, yes, Dr. Divya, you were talking about the triple P.
Localization of the placenta. Then we'll resect the segment of that.
Yeah, there are 3 Ps. There are 3 Ps. So first P is what is called as placental mapping, right? Placental mapping means you have to see whether it is the complete length and breadth of the placenta and what is the depth of invasion. So that is done by MRI, placental mapping. Secondly, what is called as selective or stepwise devascularization, right? Stepwise pelvic devascularization, right? And third is patchy resection of the myometrium. You resect the part of the myometrium along with the placenta and then you close it, suture it. So this is a triple P procedure, right? And the other one, what is called as, does anybody know about it? Dr. Kavita, would you like to speak about this?
Another one I know that nowadays they do, like they embolize the uterine artery with Teflon pellets, things like that. But
Yeah.
this is
So pelvic devascular. No, it is not theoretical.
For us, it is in this.
Yeah,
in
no,
our
no.
part of the
Most centers are doing uterine artery embolization, and it's very, in fact, they are catheterizing the uterine artery before the surgery.
Yeah.
And the moment the baby is delivered, then they insert the pellet, and the uterine artery gets embolized. Then, then they slowly remove the weight, remove the placenta.
Yeah.
And whatever is the raw area, they can suture it.
Yeah, but this is interventional radiologist's job. Okay, but then for us obstetrician, there are many centers nowadays specially dedicated for this we have, what is called as, you actually devascularize first, pelvic devascularization. Maybe you do apply the aortic clamp also. Maybe you do the uterine artery,
internal
iliac also, and even both the uterines first, so that you make the uterus devascular. And with your scalpel knife or your handle of the knife, you just curate it out the placenta, because now there is no blood supply, it will not bleed much. And then you take care of all those bleeding points, etc. So that is a procedure now what is described as uterine conservative surgery for PAS. Okay, so there are triple P, and this one is actually it is called as AMOGS MG stage. The high and the low end of the uterine artery is occluded. Okay, so through and through stitch is taken from the upper and the lower segment, that is at the level of the knuckle of the uterine artery. Okay, so that is how you can make it avascular, curate it out, and through the placenta and close it. So that is how it is. Then of course you may keep uterine balloon if at all you feel, and then the oxytocin, etc. So we go ahead with the next case now. Fourth, Dr. Varsha. Do we have Dr. Varsha? Do we have Dr. Varsha? I think, yes. Dr. Varsha?
Yes, ma'am.
Yeah. So please, this is a case for you. We have this second gravida, para 1, with 36 weeks pregnancy, and she comes to you with history of previous normal delivery with
Hello. Hello.
Hello. Can you?
Yeah, I
can
think
you?
Dr. Yes, ma'am, we can hear you.
Yes. Yes. So there was a power failure just for a moment. I hope you can see the presentation.
Yes.
Yes.
Yeah. So she was having, cervix fully dilated, fully faced, strong labor pains, fit not good, but suddenly when she examined, she found that the breech is at station +1. Pelvis is adequate. How do you manage this patient, Dr. Varsha?
Ma'am, we'll take her to the labor room. We'll assess the pelvis. If the pelvis is adequate, then we will.
Pelvis is adequate. That is mentioned here, and she has had one previous normal delivery.
Then we'll wait for spontaneous vaginal breach to take place. And we can give augmentation if the labor pain is not adequate. Then we can augment the labor by giving.
Yeah, suppose your patient, you are waiting for the spontaneous labor, spontaneous breech vaginal delivery, and suddenly your patient, she expels the rest of the body and the head gets caught. Then what will happen?
Then we'll have to assist the breech delivery. So there are many maneuvers which help in the assisting of the aftercoming health.
In fact, before going to the assisted breech delivery, what my concern is, you don't have to take the risk for yourself. Let the relatives also share, right? Let the relative also share the risk, because basically you don't be so confident that she will deliver vaginally. You say that she has delivered previously, that was head, but this is breech, and we are not sure whether she will deliver vaginally. We may have to take her for we have to take her for cesarean section, and we need to arrange for everything beforehand. If at all meanwhile she delivers well and good, but if not, we will definitely need some support from the anesthetists, etc. That is how we have to take the informed written consent also. Okay. Yes. So don't take everything, you shouldn't be so confident in this era of CPA, even though you can manage breech deliveries very well. Keep little safeguard for yourself. Say that, it's a breech presentation, which is an abnormal presentation, malpresentation, right?
Yes, ma'am.
Okay. So by the time you explain the patient and relatives, and by the time you make all the arrangements, you may, to your surprise, she just push the breech and baby may be in your hand. That is called as spontaneous breech vaginal delivery. but she just pushes her breech and, then the baby is not coming out. Then it needs assistance. So how do you take out the, only the buttocks are delivered. Now, how do you deliver rest of the baby?
We'll put the fingers inside and we'll deliver the foot of the baby, and we'll keep the back of the baby anterior. And then we'll try to we'll hold the trunk of the baby in the one arm of our one arm, and then we'll try to deliver the shoulder of the baby. We'll sweep in the sweeping motion. We'll deliver the hands in the shoulder of the baby.
Okay.
And then we'll go for a corkscrew movement. We'll take out the anterior shoulder and then the posterior shoulder. And then we'll put our two fingers, we'll put on the cheek of the baby and one on the
No. I didn't get your point. You have delivered the baby up to bridge. Just a moment.
Sorry, ma'am.
In breech delivery, it deliver it in three parts. One is delivery of the buttock, the leg. Two is delivery of the shoulders, and three is delivery of the head. After coming head. So you were discussing. You already mentioned about the Pinard's maneuver for delivery of the legs.
Legs. Yes.
And for the shoulders, you mentioned, and for the head, you're going in for the maneuvers for the head.
Yes, we can go for the Morrissey smelly wheat technique. We'll put the two fingers on the. We'll try to keep the head in the flexion position, so that.
Right. So.
And then
yeah. Which one is the one which you commonly prefer? Which one you do?
I do Mauritius smelly weird technique. However, I've delivered multiple breech.
Right.
Once I got very badly stuck because it was an extended head. And finally, although before that I had, as Dr. Sneha had said, counsel and document. Luckily, I had counseled and documented, and the party refused a C-section. They said no. So, and this was, imagine, this was a 3.2 kilo male child, which was delivered, obviously a dead child. Because once your head gets stuck, I mean, the baby's head gets stuck, there is no way you can bring out a living child. So,
yes, that is a very sad state, but I hope they have signed for whatever.
Yes, they signed. And when I told the patient's husband that, see, this is what I was dreading and this is what you ended up with. His dialogue was, कोई बात नहीं मैडम, अगला वाला हर बच्चा उल्टा थोड़ी होगा, अगला वाला सीधा होगा तो नॉर्मल हो जाएगा.
I know. See, so we have to be very cautious and don't be extra confident about anything, because obstetrics is unpredictable. So, breech specifically, the thing which is, in your favor, that it is known as a malpresentation. So definitely we should be very cautious, and of course, if at all she has had a previous breech delivery, little more, confidence. But if she is really multiparous, then of course, and you have optimum weight, maybe 2.5 to 2.75, that is the one. But more than 3 kg and definitely less than 2 kg, these are the ones which are, adverse factors. So if at all you have antenatally diagnosed, then of course you can use this, what is called as the Zatocheny-Andrews score for breech vaginal delivery, then it is useful. But I'm sure nobody nowadays knowingly delivering the first breech vaginally. All of us are going for, because it is allowed by law also. It is the official indication that primary with breech, we can straightway take her for cesarean section, right? So when you don't need to explain anything and you have a better outcome, why should we go for heroic measures, right? So induction should never be done. Augmentation, yes, as Dr. Divya also said rightly. And principles of assisted vaginal breech deliveries, always keep the back anteriorly, absolutely no traction from below or no pressure for fundal pressure from above. Just go on doing the maneuvers so that, things go smoothly, and of course follow the timings. Definitely you need to deliver the baby within that time frame, 3 to 5 minutes, not more than that, the complete delivery 3 minutes, right? That is what you have to follow. So Dr. Rani, madam, can you give us some tips on this breech deliveries? We have already discussed everything. whatever in your experience you want to share with us. Hello? Do we have...
Hello?
Yes, please go ahead.
Me. Hello?
Yes, please go ahead. Please go ahead.
I have experience. Usually what I do is that in primary with the breech presentation, if the weight of the baby is 3 or above, I usually don't try for it.
Yes.
But if it is in multi cases, I give a trial. But that case also with after taking the signature of the relatives.
Right.
And if the pelvis is adequate in second or third gravida, of course, I give a trial. But if it is failed, then go for CS. Because of the allegations that are taking place these days. But so many cases in our hospital, I have done normal delivery.
Yes.
Breech
Yes. Previously, I'm sure because I think 35 years, even we have been doing all this, but nowadays it is little difficult.
Yeah.
Okay.
Hello, ma'am.
Just
just my experience that if the breech is a preterm baby, it's very difficult to deliver out because the trunk prematurely comes out from the cervix, even at 8 centimeter.
Yes,
The
because
cervix is
it's a
not enough
soft
to
and
dilate.
flexible, and the head is also relatively big. You know, if you have a preterm baby or maybe even the small for gestational age baby, the head is comparatively or relatively big, right?
Yes,
So
ma'am.
that's the
And
reason
that
less than 2 kg and more than 3 kg. These are the adverse factors. Okay, it scores adversely. Should we continue discussion?
Another thing about breech presentation is that I just do not deliver before full dilatation. Like what my boss used to do, he used to say that, okay, keep a pad outside the vulva and wait, let the breech keep curling up in the vagina also. Do not give traction. Patience is a virtue of him, which I think all of us lack right now, sincerely. But patience is a virtue. And he said, just put a pad outside the vulva, let the breech keep coming out on its own, and wait until you see its full dilatation. Do not try to take out the baby.
Yes, exactly. It is described that let the breech descend down the perineum, and then you try and deliver her. Let the breech come on its own. Let the baby get delivered up to umbilicus. That is what is the dictum. The basic principle is, in fact, right?
Good evening, ma'am.
Good evening. Good evening.
I have a question. What is the role of external cephalic version?
External cephalic
breech, you should have masterly activity. Pushing is life-saving and pulling is life-taking. Don't pull the breech. Better you ask your assistant if the head, better you push it from your parabdominally. Pushing is life-saving and pulling is life, like it is dangerous to the for the delivery of the breech. And really you need masterly inactivity. Please give 1 minute time from nape of the neck to head to deliver, because we become very nervous. Arey, ab kya hoga? Kahin, baby. But really, we should wait for 1 minute for the delivery of the after coming head of breech. And my professor, he used to use this Pepil's forceps for delivery of the after coming head of breech. I have seen, but I don't dare to do it in my clinic. But I have seen him using this papillary forceps for delivery of the after coming head of breech.
In fact, that is what I have mentioned, the people's forceps or Piper's forceps for the after coming head. We have seen it being used, and we have used it at least once or twice in Bija Medical College and Sassoon Hospital, Pune. You really have to, it's a very different kind of forceps, it is, you have to actually sit knee down on the, घुटने टेक के बैठना पड़ता है, or actually you have to apply it like vertically, because forceps usually is forwards, downwards, forwards and upwards, but here you don't to go upwards, not like this. You have to just pull it downwards. That's all, right? So that is how, that is a difference.
Ma'am, we can also go for
Delivery,
dressing
or this
sessions.
peppers forceps and the other kind of forceps delivery. Should we discuss last day? Yes.
Ma'am, what about
Yes,
external
please.
connection?
You actually, that is external cephalic version. See, now they are not doing it, but RCOG says that whenever you have and we have practiced in our PG days, but nowadays I don't think anybody is practicing. Though people are saying, RCOG says that at 36 weeks, if you find that the patient has breech or transverse lie, you go for what is called as elective external cephalic version. Before that, you explain the patient and you see what is her choice, whether she wants to go for informed what is called as elective cesarean section or elective, and then accordingly you plan. So external cephalic version, if you are doing it agreed, but then when you try to do it, most of the time it's not successful, or even if it is successful, it may revert back to
Sound is going.
Yeah, actually, Dr. Sneha's network is slightly, I think internet connection is slightly weak.
Yeah, if the patient is RH negative, you have to give, and there is a chance of,
I really wouldn't recommend external cephalic version in an RH negative woman right now. In today's scenario. In today's scenario, I mean, if she by chance you underdose her anti-D and she turns out to be ICT positive, you've just had it. So external cephalic version is a pretty good procedure. Done well, it is very effective in converting a breech to a cephalic presentation. However, as Dr. Sneha has rightfully pointed, it may revert because it's a high floating breech. If you could actually change the presentation, change the lie, that means it was a high floating breech. So it will continue to be a high floating head and it might revert. Then secondly is that you should be very particular about how long the cord is. A short cord and you're doing ECV, you will get stuck. So, and continuously monitor the fetal heart rate during the procedure. So that you know that there is no fetal deceleration. As Dr. Sneha, Dr. Sneha.
Yeah, so actually, in between, I'm losing the connection actually. Should we go ahead with the discussion of this case,
yes,
or should we stop?
No, continue, ma'am.
Yeah, so we finish up with this case. We have this 34-year, I think, Dr. Neha Priya. Dr. Neha, hi.
Yes,
do we have Dr. Neha?
Yes, ma'am.
Yes.
Good evening, ma'am.
Yes. So hi. Good evening. Good evening. So we have this second gravida with gestational diabetes, and she comes in labor. You find that when you examine the uterus is 36 weeks, cephalic head, fetal heart is good, and cervix is only 2 centimeter fully dilated. But because she is second gravida, she progresses well. Parabdominally also contractions good. Now head is fixed, and she becomes fully dilated, fully fixed, and suddenly you find that the head is pipping out from there. But even after when the head is pipping out, it just refuses to descend. What is this condition called as, and how do you?
It is a case of shoulder dystocia. It may be a big disease, gestational diabetes patient. And whenever it happens, I will call my helpers, assistants, and I will go for
flexing the mother's legs against her abdomen, rotate the baby's shoulder. Then slowly I can take out the shoulders one by one, and thereafter I can deliver the baby. Other thing I can do that I can apply some pressure over pubic bones to rotate the shoulder also.
Suprapubic pressure.
Yes, ma'am. Suprapubic pressure. I will do posterior
hyperflexion. Hyperflexion, you said, right? That is called as Mac-Roberts manager. That means you hyperflex the patient's thighs on her abdomen, right?
Yes. Yes,
so how does it? Yes. How does it help you?
It will rotate the shoulder. The shoulder will come in AP position. Then I can take the posterior shoulder first, then anterior. If it
so the AP diameter of the pelvis becomes more and the birth canal is straightened. That is what you can get. If it doesn't deliver with this, you have suprapubic pressure, right? So which side you should give the assistant should give suprapubic pressure on which side? Right, left? How do you decide that?
Ma'am, left side.
You can see here. No, not on the left side. She is standing at present on the left side, but which side? See, you can see the head, no? So on the side of the occiput, right? On the side of the occiput. So occiput is on left side, this side. So that side you have to give suprapubic pressure so that, you know, that shoulder, that is the anterior shoulder that is stuck. So if you push, both the shoulders will come together. That means the bisacromial diameter will become less, right?
Yes. Yes, ma'am.
Yeah. Okay. So if that doesn't help, then what you do?
I will try to rotate the shoulder, ma'am.
Right. Perfect. So anterior, so posterior has already come down. So what you do is rotate the baby through half circle, 180 degree. So that now the anterior becomes posterior and it comes down, right? Okay, got it?
Yes, ma'am.
If doesn't, of course, if it fails, then of course there are many other maneuvers, corkscrew, reverse corkscrew, and then if that doesn't happen, then very sad state of affair. If you have to go for what is called as pubic symphysiotomy, you just incise the pubic, symphysis pubis. The cartilage is incised and the pelvis is widened. Maybe sometimes you may have to deliberately break the baby's clavicle, that is called as clidotomy. So these are all destructive procedures that we don't consider. But yes, definitely the message. First, what is the message? I think we would like to hear from Nivedita and Arpita madam, from you.
Most important message is that be aware. So obviously, if you see a large size baby, if you see a mother is obese, all high risk factors, GDM mothers, when you know that post-dated pregnancies, you know that these are at high risk for high risk shoulder dystocia. So moment you have on the patients, your brain, they should be, the clock should start ticking that, okay, these are high risk patients. So the next is an ultrasonography done at term, which gives you the baby's like estimated birth weight. And if you see that the estimated birth weight is 4 kilos or more, then you think of delivering. Or see, nowadays most operation even can get it. They do an abdominal examination and they say it's a big size baby. But then if you have a documentation of a big size baby, you are better equipped to say, okay, I'm going straight away for a C-section. And lastly, at your obstetric drills, your labor room team, your team of nurses in the labor room, all should be trained to manage shoulder dystocia. Because if it occurs suddenly and your nurses can't do anything, then as I said, just like in a breech, the aftercoming head is stuck. Here, the forecoming head is stuck. So then again, you lose the baby. So the nurse, not only just the doctors, the nurses should also know the drill of a shoulder dystocia.
Yes, so that is perfect as far as before happening the shoulder dystocia. Now from Arpita madam, can we hear, once you see that the head is got stuck, what will you advise? Arpita madam, do we have Dr. Arpita? Okay, so I will say few things. What not to be done. First and foremost, not to get panic. Okay, not to get panic, but be quick. call for help. Maybe call for your assistant, your staff, may call for your anesthetist, neonatologist. You don't move from that place, but definitely be calm and quiet, but quick in action. Follow all the manuals. You do hyperflexion. I think 80 to 90% of the babies they deliver with this, and another 10% or maybe with combined Mac Roberts and suprapubic pressure, another 10% deliver. So not only 70 to 80, but 80 to 90% babies deliver with this combined maneuver. Only 10% require some more assistance, and that is why you have to be very thorough with all these manuals if at all you need to. But then follow helper. Okay. So don't get panic and continuously monitor the patient and go ahead with all the manuals so that you deliver. What you are not supposed to do is don't become panic and no unnecessary pulling from below and no unnecessary no fundal pressure for that matter. It should be suprapubic pressure and not the fundal pressure. That will worsen the situation. Okay. So friends, thank you so much. I would just conclude by saying yes, intelligent anticipation, as Dr. Nivedita has already said, skilled supervision, prompt detection, effective institution of therapy can prevent disastrous consequences, but of course, not to forget communication and documentation. So thank you so much, friends, for having me here. I have thoroughly enjoyed being with all of you, thoroughly enjoyed discussing all the day-to-day practice cases with you. And thank you so much once again for all your love and affection. I just make it, a humble appeal to all of you to please vote and support for me as my candidature for Foxy Vice President from West Zone. All of you know that I was breast committee chairperson. People who have worked with me know me so well. But yes, I would definitely like to work with all of you. Though I have, had so many positions, and without positions also, I have been working for last 3 years, continuously, relentlessly. I'm trying to travel each and every place all over the country and trying to connect with the Foxians. So please do support and bless me. I want to represent all of you. Thank you so much.
Thank you,
Thank you, Dr. Sneha. Thank you, Dr. Sneha. I would like to thank everybody who's been with us today. And I sincerely request people to vote for her because, she deserves it. She's one of those people who can make an impact as a vice president, Foxy. Foxy needs good, honest, hardworking, dedicated people. It's time to make Foxy come up to a standard, and we need her. So it's my humble request to everybody. Please do support. Please vote. Please ensure that your membership IDs are updated. Ensure that you vote and ensure that your friends vote. That is also important. So please propagate her name. Thanks a lot, everyone.
Thank you. Thank you, Dr. Kavita. Thank you. Nice to have you, Dr. Rani. Madam, thank you so much, Dr. Durga, Dr. Kusum Prakash, and thank you, everybody, Dr. Jyoti Gupta, Dr. Shikha Sahai, thank you, Neha Priya. Of course, thank you to my experts, Dr. Nivedita and Dr. Arpita Gandhi. Madam, thank you so much for all your blessings and all the respected chief guests and guest of honor. Thank you so much. Thank you. It was a pleasure being with you.
Thank you. Thank you, Dr.
So
Sneha.
much.
All the best.
Bye.
We are all keeping our fingers crossed. Thank you.
Thank you.
Thank you, dear. Bye-bye. Bye. Thank you, Saiti.
Ready. Back for me. She didn't ever would.